Good morning, everyone. Welcome to today's webinar, Marijuana Use in the Kidney Transplant Evaluation Process. My name is Molly DeBras, and I'm the Client Services and Community Manager here with the Kidney Foundation of Ohio. A few quick housekeeping items. Today's webinar will last for 1 hour. Questions can be submitted using the Q&A feature on your screen, either during or directly following today's presentation. If time permits, those questions will be asked at the conclusion of today's session. And to receive continuing education credits, participants must attend the entire webinar and complete an evaluation, which will be available at the end of the webinar. Some additional information. For future sessions and webinars, please visit our website, www.kfohio.org. All Kidney Foundation of Ohio patient service programs and educational offerings in conjunction with University Hospital's Transplant Institute are free of charge. And just a quick reminder, again, there will be an evaluation available after today's session. And for those who want participating continuing education credits, you must fill out that evaluation. A little bit about the Kidney Foundation of Ohio. We provide a broad-based program of direct assistance to those with kidney disease, and we also promote and provide educational programming for the general public, renal professionals, patients, and their families. We serve a 32-county area in northern and eastern Ohio, and we have 2 affiliate chapters in Lake and Summit counties. The Kidney Foundation of Ohio remains the only health and human service agency in Northeast Ohio that continues to provide direct dollars to patients to assist them with the devastation of their kidney disease. The foundation remains an Ohio-based organization, and all the funds that we raise here in Ohio stay in Ohio to help our patients. I would now like to introduce Kathleen Perino from Hospitals.
Thank you, Molly. Good morning, everybody. My name is Kathleen Perino. I am the outreach coordinator for the Transplant Institute at University Hospitals. We have over 50 years of innovation in transplant, starting way back in 1968. And we continue to this day to provide transplantation to our patients. And I really wanted to say thank you to a lot of you on this call, because we couldn't do what we do without your help and collaboration and care of patients. So thank you to everybody on the call. I know there's a lot of familiar people on the call for us. I wanted to introduce to you our speakers today. Ray Isakala is our Director of Addiction Recovery Services at University Hospitals. He works a lot with us. We have patients that are recommended to have an IOP or seek individual counseling for their addiction. He has a very long history in this field, and we are happy to have him with us today. And then secondly, we have Chris Shea Downer, who currently is our interim administrator at the Transplant Institute. She has over 30 years of experience in transplant. So I don't want to take any more time to introduce anyone, because I know this is a very hot topic that people are interested in. So I want to get going with the program. So hand it off to Ray and Chris.
Thank you, Kathleen. Appreciate it very much. I'm happy to be here this morning. I really appreciate the opportunity to speak on the topic of the state of cannabis in Ohio and at the national level. As Kathleen indicated, I have worked with a number of kidney transplant patients over the years, and have had some very interesting and moving experiences. One gentleman, I never talked to Kathleen about this, we treated a few years ago, a transplant patient, and he was in fact addicted to cannabis, very much so. And he did just fantastically in treatment here with us, so much so that offered to be a speaker with us at our annual holiday get together with patients and graduates, and he just did a fantastic job. Very moving talk that he gave. So I'll jump right into it here. Try to stay on task. I don't have any financial disclosures to make. I have, with permission, utilized a lot of information and some slides from Dr. William Berry, a friend of mine, a psychiatrist at University of West Virginia, who's truly an expert in cannabis law, outcome measures in terms of pain management and psychiatric disorders that people are trying to use cannabis for, with hoping that would help their situation. I have, what did I say here? I am biased. You'll figure that out as an addiction professional. I have worked many years with people who have problems with cannabis. Not everybody who uses cannabis ends up with a problem, but those who end up in my office tend to have progressed into trouble with cannabis. So let's go ahead and get started. Here's our objectives. We're going to try to identify the diagnostic criteria for those folks who do cross over into cannabis use disorder. We're going to try to discuss the legality, illegality of cannabis in the state of Ohio. I'm going to tell you what I know about how people get a medical marijuana card, and we'll try to talk a little bit about the pros and cons of chronic use of cannabis in an effort to manage pain, anxiety, etc. So we're all very confused about cannabis in this country. It's legal in some form in 38 states. In Ohio, we have approved the use of medical cannabis several years ago. In Ohio, on the ballot, I think in January, we're going to vote for the legalization of recreational cannabis. I guess that vote was supposed to happen in 2022, but there were some difficulties and it's been postponed. Now, what's confusing is that marijuana use is illegal at the federal level. So it's very complex to try to explain why is it going to be legal in Ohio, but it's illegal at the federal level. And so it just is symptomatic of our confusion about cannabis in this country. If you're caught with less than 100 grams, that's 3.5 ounces in Ohio, you can pretty much expect a fine. Different states are going to vary, but let's keep in mind that we're all confused legally about the state of cannabis use. Again, I'm going to mention cannabis use. Cannabis is considered an illegal substance at the federal level. It's never been approved for medical use via the FDA or any scientific body, but states have taken it on themselves to pass legislation for medical use as well as recreational use. So cannabis is not an FDA approved drug. It's a Schedule I substance at the federal level. The active ingredients are cannabinoids. The biggest one, of course, is tetrahydrocannabinol, THC, which causes the high, the euphoria that people are after. There are synthetic medications that are approved. Dronabinol is also known as Marinol. It's been a medicine approved by the FDA for a few decades, I believe. It's used for, it's an antiemetic used primarily in cancer patients who are undergoing chemotherapy or HIV/AIDS patients. Here's the thing about Marinol, why it's not such a popular medication. It doesn't get people high. It's a slow acting medicine that does in fact act as an antiemetic, but it doesn't really have the euphoria that's associated with medical marijuana and with recreational marijuana. And if you peel back the layers of the onion, that's really why people want to use medical marijuana, is for the high as well as the recreational marijuana. Doctors in Ohio can't write a prescription for cannabis. Our patients and even healthcare professionals, oh yeah, his doctor's prescribing cannabis, medical marijuana. No doctor can prescribe marijuana. No one knows what a dose of THC should be. No one has researched, is it safe? Well, that's not true. The FDA hasn't researched, is it safe? How much should people use? Is it effective? It's all no regulations are involved. So what do I say it next? How people get a card is, well, let's go back here. A couple comments. No one knows what's a safe level, no dosage, no safety standards. I make some jokes. I don't know if it's too early. I know there's people on both sides of the fence. I get it. This might anger some people, my position, but I make some comments like, yeah, you know, no one knows if the dog peed on the cannabis out in the backyard that people are growing. There's no safety standards. No one knows what's in the cannabis. Dispensaries are influenced by the industry, and the dispensaries employ no medical people. They employ what's called tenders, who are supposed to be the experts in, this one is good for arthritis, this one's good for foot pain, this one's good for arm pain. All just anecdotal stuff that has no medical basis. There are 400 compounds in marijuana. We don't even know what all of them do. 60 of them are psychoactive, pharmacologically active. Each individual has a different reaction to these compounds that are in cannabis. Here's a picture of a cannabis plant. Here are, so I'm going to say it now. How I say it later, but how we get a medical marijuana card in Ohio is this. I find a doctor who's been approved to sign a paper that authorizes me to use cannabis. The doctor there, and these are cannabis doctors around Ohio. You pay some cash and you go to see them, and you say, "Doc, I have one of these disorders," and the doctor says, "Okay, very good." And he or she writes on a paper, you know, signs a paper and enters me into a database. Yes, this patient is permitted to use medical marijuana in order to treat one of these disorders. The doctor doesn't say how much cannabis they should take, how potent it should be, how many times a day. They just hand a paper over to you and say, okay, now take this to the dispensary. So these are added as weeks and months go by. And some of these are very serious, terrible diseases. We all get that. But if I have a disorder like PTSD, I simply, file a petition, get some advocacy behind me, go to the board, and we make a case for why this should be, why medical marijuana should be approved for such a disorder. So I think there's 21 of these, and they're changing all the time. So again, I have to seek out a cannabis physician. He or she verifies I have one of these conditions. They approve me, and then I go to the cannabis dispensary and purchase whatever I choose. I call these dispensaries, the Cheech and Chong store. They're not exactly CVS. They're not regulated in terms of what they're selling. They sell lots of things that make you high, and they're talking people into, yes, this will work for this. This will work for that. Forms of medical marijuana that are authorized. This is straight out of the Ohio Administrative Code. We call it flower or leaf. That's the plant. Oils, tinctures. These are very potent substances that are high concentrate THC. There's the plant material, edibles, lotions, creams, etc. Now here's what's interesting and goes along with our confusion. The law prohibits the use of, you can buy the cannabis, the leaf, but it's illegal to smoke it or put a match to it. How many people you think are going to buy a cannabis at the dispensary and not smoke it? Come on. We're supposed to vaporize it or eat it or something, but people I know go home and smoke it. Now on the street, THC has become very, very potent. Let me say, for no great reason, not everything I know about cannabis has been learned from textbooks and journals. I attended Kent State in the 1970s. We'll leave it at that. I haven't used cannabis or alcohol or any drugs for decades, but just, not everything I know came from the textbooks. Right around here in the 70s, THC content in cannabis was about 2%. Now, this is only going up to 2011. It's increased tenfold in these by 2011. Up to, this graph shows 10-11% THC. So that's 5 or 10 times stronger than the marijuana in the 70s, which makes it a very potent drug. Now, in these dispensaries, we are purchasing products with a THC content up to 90%. These are very strong concentrates of THC. They are called, they're waxes, they're oils. This shatter is called glass. These are very, very potent. No research indicates that anything above 10% is helpful. The Dutch, who are no strangers to drugs being used, concluded that anything over 15% should be considered a hard, THC should be considered a hard drug. So my suggestion is that these drugs, waxes, oils, tinctures, cartridges that contain up to 90% THC are very powerful drugs, and they're very powerfully addictive. Here's a graph of how many 12th graders are vaping highly potent THC products. I think it's 14% of high school seniors are using these very potent products. Vaping has kind of changed the landscape of how powerful some of these, the THC as well as the nicotine, can be ingested. Boy, that's small. I'm sorry. So a couple comments on the medical marijuana legalization. Really, the agenda for medical marijuana being legalized in states is a gateway to get recreational marijuana legalized. Any state where medical marijuana has been legalized, shortly thereafter, it's recreational marijuana is legalized. And in mine and many scientists, I'm not a scientist, but many scientific approaches, scientists, very well-learned people say, yeah, the whole goal is simply to get recreational marijuana legalized. Once it's in and we can say, oh yeah, it's a medication. How bad could it be? We shortly thereafter say, well, yeah, then why don't we just let everybody smoke or let it be legalized? So we're undoubtedly going to legalize recreational marijuana in Ohio in the next year. I think 38 states have some form of legalization marijuana. But here's the thing that some of us have issue with. Why should we mislead people that it's a medicine, not FDA approved? I ask people this. Now, I can't see any of you, but if I could, I'd say, please raise your hand. How many of you voted that acetaminophen should be a medicine? How many of you voted that oxycodone should be a legal medicine? None of us. We placed it in the hands of scientists and researchers. Why do we place this decision about a medicine in the hands of lay people and people who like to get high and people like me who aren't FDA scientists? Why do we place this decision in the hands of lay people and people who really are advocating for legal marijuana? Just one of those things. So I challenge patients when they come, oh yeah, I have my medical marijuana card. Oh yeah, I see that. I hope everybody knows what an ORS is, the Ohio Prescription Automated Report. I have to have an ORS on any patient I see. And cannabis, even though it's not an approved medication, if I'm buying it at the Cheech and Chong dispensary, it does end up on my ORS. And these are typical things I read on an ORS. Here's what the pure people are purchasing. Maui Wowie. Does that, Purple Haze, if you're my age, that's a Jimi Hendrix song about LSD. Orange Kush, Orange Crush, Skunkweed, Head Trip, A Token of Your Love. These are on people's pharmacy records. Puff Puff Kiss Kiss. So I ask people, now here, I'm looking at your prescription record here. Do these really sound like medicines to you? Or do they sound like, things you want to party with? And people say, well, yeah, I'm embarrassed about what they're called. Puff Puff Kiss Kiss, does that sound like ibuprofen or fluoxetine? No, it sounds like something you want to party with. So it is what it is. If you go into a marijuana dispensary, what I call the Cheech and Chong stores. You'll see these things that are marketed towards children. These all have high concentrates of THC in them. I don't know, Doritos, stoned Oreos, you know, stoned Lifesaver gummies. These you can see can be fall into the hands of kids at home and be eaten accidentally. And these things are powerful, these edibles. Here's some double stoned Oreos, tricks, you know, here's a drug containing high concentrates of THC. Is that what I should treat my cancer pain with? I'm not so sure. This is the inside of a cannabis dispensary. There are these stores with many selections. Everybody who works, I'm being judgmental, I know, you can come back at me. Everybody who works in these dispensaries looks very happy, like this young man. He's had a lot of education in how to sell weed to the public. Now, these next ones are offensive. I'm gonna go through them quick. Here's, oh wait, not this one. Here's another one. This is inside a dispensary. This magical, romantic vision that we like to have about cannabis. These are super beautiful cannabis buds under, you know, they're like gems or they're magic. And this kind of looks like a religious setting, all having to do with the romanticism of cannabis and how magical it is. Now, these next ones are a bit offensive. My only objective here is to show you these are marketing for medicine. People, these are not marketing for weed to get high. They're under the illusion of this is medical marijuana. Let me show it to you in my bikini. Here's marketing. This says something. Let us get you your medical marijuana card. So again, these are very similar to liquor ads. And we know we drink liquor to get high, but these are under the illusion of marketing. I'll get rid of that. We don't need to see that. Marketing a medicine. So how, come on. We don't need people in bikinis selling ibuprofen. So daily use of cannabis has gone off the chart. Near daily use, it's up in, oh, this is hundreds of thousands of folks. 9 million people are using cannabis daily. We're most concerned about young people using cannabis daily, our teenagers, but 3 million, it rose to 8 million. Lung cancer, we're worried about. We have lots of history with that. Cannabis is the most frequently used illegal drug in the United States. These are high school seniors who are using cannabis. I'm sorry, we've got some 12-year-olds and 16-year-olds, 1.7 million using cannabis every month, which might be every week or every day. And we've got 20 million people in their 18 to 20s using cannabis. So it's the use since we started legalizing and medicalizing cannabis, the use has gone off the charts. About 43% of people in the United States are using cannabis or hallucinogens in the last year. Young people, I should say, 19 to 30. This is a lot of people. We have ER visits related to cannabis, these edibles and so forth. People can go into panic attacks and have hallucinations because they're very potent drugs. We know that it causes many problems cardiovascularly, lungs, heart. cannabis use is highly related to an increased risk in depression and suicidal behavior. No doubt about it. High prevalence of adolescents using cannabis is causing a lot of concerns. Let's go here. People who use cannabis are much more like their PTSD is worsened. Their bipolar disorder is worsened. Their major depressive disorder is worsened. This is from the Journal of Clinical Psychiatry. These are a couple, well, this one is one of the approved uses in Ohio. And quite frankly, our science tells us it makes PTSD worse. It makes anxiety worse. What are the risks of getting a card? 3 times more likely to get addicted to cannabis use disorder than the population. Probably no improvement in pain, anxiety, or depression. Pain, the jury's out. Some of our science says really there's no real scientific benefit to reducing pain. Honestly, though, folks, if I'm dying of pancreatic cancer, I don't care. I mean, people shouldn't care that I use cannabis, but let's not confuse people and say it's a medicine, because people are really misled. No benefit on physical or emotional functioning with chronic non-cancer pain. Let's move to addiction, what this looks like. One study suggests 3 in 10 people who use cannabis are going to cross over into addiction. This is if I use cannabis before 18, my odds ratio doubles to that I'm going to become addicted. Here again, I'm sorry, these are so small. These are our criteria for cannabis use disorder. Using more than loss of control, repeated failures to quit or control, spending a lot of time using, buying, fantasizing, drawing pictures of marijuana, craving marijuana, etc. Using in spite of problems, using in spite of mental health problems, experiencing withdrawal symptoms. And we have 13 of these criteria that we use to make a diagnosis of a psychiatric disorder, cannabis use disorder. There is a cannabis withdrawal syndrome that we recognized for a century. We told people, no, there's no withdrawal from cannabis. Yes, there is. The cannabis today is so powerful. When people are using it daily and they stop cold turkey, they may experience irritability, anger, aggression, nervousness, anxiety, nausea, insomnia, restlessness, abdominal pain, shakiness, sweaty, fever, chills, headache. And this is a clinical syndrome we recognize. There's a vomiting syndrome that heavy marijuana users experience. What is it? 1/3 of people use marijuana that's so potent that they vomit for about 5 hours in a day. It's unlikely that cannabinoids are highly effective with chronic non-cancer pain. Makes these things worse, as we mentioned. People who use cannabis are very much more likely to have anxiety disorders, mood disorders. And so we're confused as a nation about cannabis. We have poor data that suggest it's a good medicine or that it's effective as a medicine. we have a large segment of our population who romanticize cannabis, think it's a magical potent elixir that's great for everything and that everybody should smoke. And we have it's a very difficult addiction to treat. There's a lot of insidious dependency issues with cannabis. There's rituals and there's romantic ideas. There's this sense of unique experience, novelty. When we're getting high, we think everything is new and better, and it's really just because we're high. So we don't have great medications to help with cannabis addiction. So I'm going to stop there. As you can see, I have a point of view that cannabis is not magic. We probably shouldn't be misleading people that it's a medicine. It is addictive for some people, not everybody, and that we're pretty clear that we're going to have legal recreational marijuana in Ohio. So I'm going to stop there, Chris and Molly and Kathleen, and I'm going to turn it over to Chris. And I guess if we have questions, we can address those later. Thanks.
Okay, go right on ahead, Chris.
Thanks, Molly. Thanks, Ray. And hi, everyone. Thrilled to be here. Certainly thank KFO for allowing me to be here. I think the information that Ray shared, I think sets a foundation, right, for us to kind of shift into the transplant realm of healthcare, and talk a little bit about the effects of cannabis use in the transplant process, as far as healthcare management, but also the effects that it could have on the patient and their transplant journey. So if we think about the transplant process just in general, I would imagine that many of you on the call are kind of familiar, with this, but for those of you that are not, a patient gets, certainly referred to a transplant center. They go through a head to toe, inside and out type evaluation before a decision is made regarding their candidacy for transplant. And then if they're deemed a transplant candidate, they're placed on the wait list. And this time waiting can be very variable, right? Dependent upon a lot of things until they're called for their transplant surgery. And then most centers still in the United States are following their transplant recipients lifelong, or in collaboration with community physicians. So in general, this is, kind of the process from a super high level. Today I'd like to focus, on the transplant evaluation and listing section, right? So, when we evaluate someone for transplant, we're looking at a lot of things, right? So today we'll, talk about the role that cannabis has in that part of the transplant journey. But I also challenge you to consider and include the listing phase of the patient's journey in this discussion as well. We do the evaluation and determine if the patient is a candidate for transplant, but while they're listed for transplant, we're continuing to do that. So the goal of the transplant team is to keep that patient as healthy as possible and as ready as possible for transplant. And it's not just about getting through the surgery, but it's really about promoting a lengthy and quality filled life afterwards. So the evaluation, right, I kind of mentioned already, the goal is to get to what we call the selection meeting. And that is where the transplant team gets together and discusses the results of the evaluation and determines the candidacy for transplant. And then during listing, there are periodic follow-ups that the patient is required to meet. So typically, Well, first of all, the wait time on our wait list for kidney transplant across the country can be variable. But it could be months to years. And so during that time, we do bring the patients back, all transplant centers do, for periodic updates. And so we want to be sure that they're staying as healthy as possible. We want to be sure that there's nothing going on or that there's new comorbidities that exist in the patient's life that would cause us to maybe treat or change their plan of care in order to optimize their outcomes. And just, as a reminder again, we need to optimize the patient to have a successful surgery and then outcomes after transplant. So if we think about the cannabis use of a patient, through their transplant process, I kind of stole this slide from a talk that was done not too long ago, a few months back. We have a consortium here in Ohio, the OSOTC. So it's a transplant consortium within the state of Ohio, that has been around for many years. It's the last state in the country that has this consortium, and they provide guidelines that the transplant centers within the state of Ohio follow regarding substance use and dependency. And so I just thought that this was a great kind of visual, to pull a lot of kind of complicated information together. So when we think about, diagnosing, a substance use disorder with the DSM-5, there's a variety of factors included in that. And then the patient is kind of categorized as having, a mild disorder, moderate, or severe disorder. And then that follows through with what the transplant center's recommendations are in order to optimize, the patient's situation for success through the transplant experience and journey. There we go. So, kind of approaching transplant patients' cannabis use, I think is a very individual evaluation. And we see this in the literature. We need to, from a psychosocial perspective, from a psychological perspective, from a physical perspective, look at each patient individually, see what their patterns are, see what their use is, see how it affects them, see if it's how it affects their behavior, right? Those kinds of things. And so, I think, cannabis use is, one topic that we're talking about today, but, we evaluate other things within the evaluation and the listing phase, in a similar fashion. This is an issue encountered frequently by transplant teams across the country. And it's really multifaceted. And it's really important to have a strong kind of mature transplant team that's able to discuss, the factors surrounding each patient and decide what is best for them. And I think that makes it difficult because there are inconsistent policies across the country within transplant centers. And I think some of the things that, Ray shared, right, kind of feeds into that, right? It supports some of the challenges that we have, and, mentioning the, no approval by the FDA, the lack of kind of dose and potency information, the safety standards behind the uses. And then, if we determine that a patient has a dependency or an addiction, there really isn't, great ways to treat that and to help the patient to become abstinent moving forward. So, think about, the perspectives too, from an insufficient literature support perspective, right? As far as treatment for any psychiatric or substance use disorders, and this is throughout the transplant process. So this is whether you're a candidate for transplant prior to transplant or post-transplant in recipients. So, I think there's an increasing amount of literature that's out there. But I think that a lot of the literature that I read in regards to transplant, share some of their experiences and the challenges that they have in managing this, but, there's still a lot of variation. Encourage ongoing abstinence if there is use for psychiatric or substance abuse or substance use disorders. Certainly I think is an ideal situation to be in and an ideal direction to go. Engaging in addiction treatment and remaining abstinent with a cannabis use disorder kind of goes along with that. Again, trying to set up, how much harm is it doing? But again, trying to set the patient up for the ideal, the best situation we can get them in for success through the journey. And regardless of whether it's legal or not, referring to a specialist for assessment totally makes sense. There are transplant centers that have addiction specialists. There are transplant centers that, they're seen by, they consist of a social worker, they consist of psychologists, they consist of psychiatrists, they consist of addiction specialists. Many of those roles are accessible, right, in order to look at where the patient is and how we can best support them and help them. And then again, having an interdisciplinary transplant team that is strong is certainly necessary to be able to evaluate and determine the candidacy for transplant. So I find I've worked through over the years, I've worked at multiple transplant centers, and I find that everyone is, I'm not someone that says never very often, but everyone is never going to be happy, right? So, you kind of have to discuss, you have to come to an agreement as a team, and you need to move forward in that direction, for the best benefit for the patient. Some of the adverse events that we see out there of cannabis use pre-transplant, use pre-transplant in the literature does not seem to be associated with any adverse events post-transplant with the graft, with the transplanted kidney. But it is associated with increased rates of psychosocial issues, right? So we may see alcohol use and a drug use disorder along with it. Because it can alter our decision-making and our judgment. We may see some non-compliance. And we've talked about the benefits or lack thereof with psychiatric disorders. So use post-transplant, there's a little bit more, I think, in the literature in regards to this, but there is some documentation that cannabis can interact with immunosuppressant drugs. So the tacrolimus that patients are on, or if they're on cyclosporin, the transplant center, will need to kind of adjust their standard type treatment with the immunosuppressant drugs that the patient takes. And so, when we think about the fact that there's not, consistent kind of dose or potency standards for cannabis, then that can make this extremely difficult. And so when we think about the immunosuppressive drugs, this is the thing for a transplant patient that makes them different than any other surgical patient, right? Because we suppress their immune system so that they don't reject their new organ. So the difficulty, having an increased difficulty in being able to manage their drug levels and their immune system suppression with the risk of rejection and or infection can become pretty complicated and can affect it. There's not any significant documentation in the literature, but it just makes sense, right? That it could become more complicated and more difficult to manage someone post-transplant towards success. There's definitely concern around infection, fungal type infections, Aspergillus in particular. And I can share from personal experience that this is a pretty impactful experience to have. So, you know, in the literature, there's very, very little evidence of how often this can occur. But I can share with you that it's been a number of years, but as a transplant coordinator years ago, I was caring for a patient, non-renal. He did not have a kidney transplant, another type of transplant, but he was a huge advocate. He was my patient, and he was a great guy. I really came to become very fond of him, but he was a huge advocate. And at the time, and this was several years ago, he was the biggest advocate for legalizing marijuana in the state of Ohio. He was creating a cookbook. He was just a huge advocate. But unfortunately, this is a guy that developed aspergillus after his transplant, probably about 6 to 8 months. And he had an absolutely difficult medical journey and did die. Aspergillus is very difficult to treat. It's resistant to a lot of antibiotics. And so he had a pretty significant decline over a matter of a couple of months. And it was from a healthcare provider perspective, a very difficult thing to not be able to help him and to clear this. But certainly it was a horrible experience for him as well and his family. So I think, you know, those that are out there and have had experiences like this, you know, that we feel, you know, may be contributed to by the use of cannabis, I think it becomes difficult for us, right, to move forward and to realize that, you know, the percentage of incidence is extremely low, but if you're within that low percentage of incidence, it's absolutely a difficult thing to have to experience. Neuropsychiatric disorders, we touched on a little bit, right? So using cannabis used for maybe anxiety disorders or other types of medical diagnoses. Non-adherence can certainly occur, you know, based on the alteration in judgment and cognitive functions such as memory, attention, and learning, which could certainly contribute to compliance, right? Ability to take medicines every day when you're supposed to. And Ray touched certainly on the cardiovascular impact as well, which I guess this could apply to both pre-transplant or post-transplant. But if they occur pre-transplant, you know, may have a direct impact on a patient's candidacy. So I include this slide. How are we on time? Oh, okay. We've got a little bit of time left. So, you know, I include this slide because transplant is one of probably the most regulated areas of healthcare that's out there. And so it's interesting to me that we have so much regulation, but there is, you know, so much disparity as well. So I think that when we think about the disparities, that the transplant community does have a duty not to perpetuate stigma associated with alcohol, with cannabis, or any other, you know, type of use disorder that a patient may have. You know, I think that the distinction between medical and non-medical use is hazy, and we've heard a lot about that, you know, through what Ray shared and the effectiveness of cannabis in different types of situations. And the lack of standardization really causes, you know, unfairness. In many ways, you know, patients could be accepted at one transplant center, but not accepted at another. And so just to give you a couple examples, I won't go through all of these, but I found some instances in the literature, you know, kind of showing, you know, that disparity and the approaches of different transplant centers. And so, you know, in California, there's 2 centers out there that screen candidates carefully, but they don't attempt to stop people from smoking cannabis. You know, here in Ohio, we have the consortium that I mentioned. We have one center here in the state of Ohio in particular, where if a patient has a medical card, then they're okay to move forward. Otherwise, the patient is assessed for a use disorder. There's a second center that's a bit more strict, but they are having conversations, kind of loosening up with the medical card. And then, when we look at the adult population versus pediatrics, there's differences there as well. And pediatric being a very, protected population, but also really trying to promote, communication and compliance, in a situation, with kids growing and developing, through adolescence to adulthood, that, there's just some baseline challenges, right? In addition to, what this could cause. And then in North Carolina, they do a lot of, assessing how and why patients are using cannabis. So is it a coping mechanism? Is it just for fun? But after the patient is evaluated, really any type of use could contribute to denial of transplant, depending on the effect that it has. Some of the literature gaps that we have, and Ray mentioned some of these, but certainly from a safety perspective, trying to create and develop a comprehensive list of drug interactions, does not exist at this time, and certainly the product safety that we've talked about already falls into that category. Studies to determine the true risk of infection and rejection, graft failure after transplant is important, and the effects that those cardiovascular events have on a patient's outcomes. And then, from a quality, right, contamination with pesticides, contamination with heavy metals, having accurate labeling and regulation, can be very important to, help us to move forward in an intelligent way, around cannabis use and transplant. So just kind of, as a summary, I think legalization continues to increase. We know without the FDA approvals, without the safety standards, without the availability to treat the addiction effectively and consistency. We see increasing data surfacing regarding the effect of cannabis on recipient outcomes. And I think the variation certainly amongst transplant centers will continue until we can fill many of these knowledge gaps. So some of my resources listed here. I'm certainly open to any questions. Molly, I know we're kind of tight on time.
Thank you so much, Chris. We're great. We do have a couple questions from the audience. And so a couple of the quick questions, and I think they have been touched upon. This is a question for you, Chris. Since there is such a wait for transplants after listing, would you list a patient even with the history of marijuana usage if they're working to decrease or eliminate the usage?
Oh yeah, that's a fabulous question. I think, again, I think you'll find variation among transplant centers. But in my experience, I've worked in 3 different transplant centers so far, across, hopefully no more in my career. But I think that that's definitely a good place to be, right? So, and I think that the transplant team will kind of set those parameters for the patient. But I think that, we're able to measure, right, the amount of cannabis in a patient's system. And so, if we're working to help them become abstinent and we see those levels going down, it's definitely a good thing. I have, seen, depending on, other factors certainly in the picture, but I have seen patients listed when they're headed in that right direction. I've seen other centers just through colleagues across the country that are more strict, right? And they want to get to that goal point before they'll list the patient. I hope that answers your question.
I think that definitely does.
Okay.
And that kind of tapped into another question that was posed by the audience with like the mitigation of how to, help the patient through trying to become abstinence or decrease usage. and how to mitigate those barriers. And that may be, a question for Dr. Ray as well too, in regards to, and he lightly touched on this during the talk as well, with, getting a patient into addiction services treatment. Does that can come obviously if from the transplant center, if like in UH's case that, they're luckily able to have a department for addiction services. How, and I guess this is the question for Dr. Ray, with what are some of the mitigation strategies? How, can a patient get referred for treatment? Is it inpatient treatment, outpatient treatment? He mentioned that there are some medications, but not very many in regards to the effectiveness of, use in reducing cannabis use. It's kind of a garbled question, but I'll turn it over to you, Dr. Ray. If you'd like me to repeat that, I would certainly
Sure.
do so.
Well, first we would, conduct a thorough assessment and help to determine if there's a use disorder, if so, how severe, and if so, what level of treatment would be recommended. We have only outpatient treatment here at UH, and that would be the appropriate level of care for cannabis use disorder. We're not going to get cannabis use disorder patients admitted to inpatient centers. There's not a medical necessity. And we treat it like any other substance of dependence. We would help the patient strive for abstinence if they are in fact diagnosed with a use disorder, and they would be involved in education and group therapy here 3 times a week, maybe for 6 weeks. We don't have, we're highly responsive. Let's say Kathleen calls us and says, oh, we have a patient and we want to have assessed. We'll see them within a day, and we don't have any waiting lists to enter people into treatment. And so, yeah, we treat it just like an alcohol dependent patient. Your goal is to stop the use, develop coping skills, develop styles of living, life on life's terms without a substance. And again, this is only for people whose cannabis use is impairing their functioning. What we see with cannabis use disorder is a lowering of motivation, an increase in depression, money problems, etc. People whose functioning has really been impaired. And so those are folks we would enter into a traditional, style of treatment. My medical team here sometimes uses off-label gabapentin in people with that severe cannabis withdrawal. It seems to mitigate some of the irritability, anger, feelings of despair for a while, a short-term trial of gabapentin. But perhaps they have a co-occurring anxiety or mood disorder, and that also can be addressed with safe medications.
Okay, great answer. One more quick question from the audience. And this is an interesting aspect that I don't know was touched upon during the presentation. What happens if there's a living donor who uses cannabis, but who is willing to donate? How does that affect the evaluation process? And that'll go to you, Chris.
No, that's a great question. I think that living donation programs tend to be a bit more conservative in this area. From a literature perspective, I only saw one article in relation to living donation programs and cannabis use, and they also kind of state variability. But, I think if we think about the nature of, a living kidney donor, this is someone that's going to have surgery, a totally healthy person, right? Going to have surgery that they don't need to donate a kidney. We don't want to set them up either for anything but success. And so I think it's a matter of assessing the effect, the use, right, of the cannabis, but then also the effect that it's having on their life. Because I think that if the transplant center is, suspicious or assesses that the cannabis use, may alter their, ability to be compliant with follow-up appointments and things like that, then that would certainly affect negatively, right, their opportunity to be a living donor.
Okay, one final question came in, and I think this would go to you, Dr. Ray. So you mentioned that dispensaries do not have actual medical staff or certified medical staff. I guess one person in the audience had inquired as to why then do dispensaries have pharmacists, quote unquote, working for them. And given how unregulated the marijuana industry is, why do these dispensaries then advertise that they test different strands of the marijuana?
I don't know. I don't know that dispensaries have pharmacists, quote, working for them. I do know that their products have to be listed on the OARS, the OARRS report. The next, I'm sorry, I can't give you a straight answer about why the research. I mean, Maui Wowie is great for hand pain. Purple Haze is great for shingles. Kiss Kiss Puff Puff is great for back pain. I'm sorry, there's no scientific evidence that any strain is better. It's all just cannabis with THC in it. And so it's a marketing thing. It's a magical thought process that, oh, this one is really good for this disorder. And you can tell I'm jaded, and I don't think it's founded in any scientific empirical process.
Okay, that was our final question for today. Thank you so much, Dr. Ray and Chris. You provided a wealth of wonderful information. So thank you again for your time and sharing your knowledge. That concludes today's webinar. In the chat feature, I would like to mention that there is the link for the evaluation. Yet again, that does need to be completed, especially if you want to receive continuing education credits. And with that being said, I would also like to just kind of share that the Kidney Foundation of Ohio does have a newly created transplant education video series. The links to that are available on our website. That kind of dovetails in with what Chris was saying in regards to the transplant evaluation process. That is designed specifically for kidney patients here in Ohio. It's a great resource. Please feel free to check that out as well. And thank you again for attending today. Have a great day, everyone.
Thank you.